So we are going to go ahead and get started. Good evening, everyone. My name is Elizabeth Aloni. I'm with Schneps Media. Schneps Media is the largest local media company in the New York metro area. We publish over 70 newspapers, magazines, websites, webinars, podcasts, and events throughout Queens, Brooklyn, the Bronx, Manhattan, Westchester, Long Island, the East End, and Philadelphia. Today, I'm really thrilled to bring to you this webinar, Breast Cancer, Risk, Symptoms, and Treatment Options. October is Breast Cancer Awareness Month, and this year, about 281,550 women across the U.S. will be diagnosed with breast cancer, and about 43,600 will die from the disease. All women are at some risk for breast cancer. However, although the majority of breast cancers are in women over 55, age is certainly only one consideration. A variety of things can influence breast cancer risk. And we're going to talk more about that today with a panel of breast doctors we're fortunate to have here from NewYork-Presbyterian Queens. And they're going to raise awareness about breast cancer, its risks, symptoms, and treatment options that are available. So I want to welcome the doctors. First, I would like to introduce Mamit Malik. Dr. Malik is a board-certified general surgeon specializing in breast surgical oncology. Dr. Malik receives her surgical training and practice in Flushing, New York, and she has an interest in variations in breast cancer presentation and disease in diverse patient populations. Dr. Malik is also an assistant professor of clinical surgery at Weill Cornell Medicine and director of the Breast Center at NewYork-Presbyterian Queens. Dr. Malik is a fellow of the American College of Surgeons and member of the American Society of Breast Surgeons, and has presented research on breast cancer and surgery at national meetings. Dr. Malik completed her Doctor of Osteopathic Medicine at New York College of Osteopathic Medicine and served both her internship and residency at New York-Presbyterian Queens. She pursued her fellowship in breast surgery at St. Luke's Roosevelt Hospital. Welcome, Dr. Malik. Next, please welcome Akama Ravi, MD. Dr. Ravi is a renowned leading radiation oncologist at New York-Presbyterian Queens and clinical professor of radiation oncology at the Weill Cornell School of Medicine. Dr. Ravi is recognized as a leading expert in the field of radiation oncology with expertise in breast and gynecologic care. Dr. Ravi earned her medical school degree from Kasturba Medical College, Mangalore University, and her radiation oncology residency with board certification from Bangalore University in India. She then completed her radiation oncology residency training at New York-Presbyterian Hospital, Weill Cornell Medical College, and is board certified in radiation oncology by the American Board of Radiology. Her academic and clinical interests include breast cancer, gynecologic cancers, and general radiation oncology. Dr. Ravi is keen on exploring new ways to improve her patients' quality of life and is a proponent of complementary therapies that may expedite recovery and enhance wellness. She was the principal investigator of a study that evaluates the efficacy of supplementary Reiki therapy for breast cancer patients during radiation therapy, and this work was presented at their annual meeting. Dr. Ravi has presented in several national and international meetings and is published in journals as well. She is a peer reviewer of several cancer journals. She's a member of several medical and oncological societies, including the American Society for Therapeutic Radiation Oncology. Welcome, Dr. Ravi. And now I would also like to welcome Lauren Elrada MD. Dr. Elrada is an attending physician in the Department of Medical Oncology at New York-Presbyterian Queens and an assistant professor of clinical medicine at Weill Cornell Medicine. Dr. Elrada specializes in diagnosis and treatment of cancers and benign and malignant blood disorders. She has a special interest in breast and gastrointestinal malignancies. She is a member of the American Society of Hematology, the American Society of Clinical Oncology, and the American College of Physicians. After graduating from Ross University School of Medicine, Dr. Elrada completed her residency and internship at New York-Presbyterian Queens. She served her fellowship in hematology and oncology at Newark Beth Israel Medical Center. Dr. Elrada was named a Castle Connolly Top Doctor for Cancer from 2016 to 2020 and awarded Exceptional Women of Medicine in 2020. We are certainly fortunate to have such knowledgeable and experienced doctors with us here today. Thank you, doctors, for giving your time to us today. So I'd like to get started with a very important question. How do women get breast cancer?
Thank you, Elizabeth, for the wonderful introductions. I appreciate you having us here tonight, and I'm glad to be here. So the first question that you ask is a broad question because there are many things that can contribute to women developing breast cancer. As we all know, the older we get, the more at risk we are for developing any type of cancer, but breast cancer does increase with age, and most of them are diagnosed after the age of 50. We know that there is a genetic predisposition to having breast cancer, although that is about 15% of cases. Most of these cases are sporadic breast cancers, which are breast cancers that develop for various reasons. The most common reasons why women develop breast cancer is exposure to hormones. And those are, mainly the estrogens that we make in our bodies. Women who have an early reproductive history, for example, get their period at an early age or have menopause at a late age tend to be exposed to estrogen for longer periods of time, which increases the risk of breast cancer. Having dense breasts can also put patients at risk for developing breast cancer because dense breasts have a lot of fatty tissue in them, which store estrogens as well. And we also know that patients who have had a personal history of breast cancer are at higher risk of getting breast cancer. Patients who have used oral contraceptives or estrogen therapies in the past are at higher risk. We know that obesity tends to play into correlating with higher estrogen levels and development of breast cancer, and other things like alcohol consumption, lack of exercise, and so on. So there are variable risks that put patients at risk for breast cancer. And these are some of the questions that we ask patients in our office when they come to see us to try to delineate what the cause is of their breast cancer.
So it is so important to really be to give all the possible information to your doctor because there are so many potential factors to consider as you're sharing here.
That's correct. And the other thing that I wanted to mention that I forgot to mention is that those who have undergone previous therapies for other cancers or radiation, for example, or chemotherapy tend to play a role as well. So there are environmental exposures as well as medical exposures that patients may have had in the past that can put them at higher risk.
And I just want to chime in as well. Thank you once again, Elizabeth, for that lovely intro. That Dr. Elrada has outlined beautifully the multiple causes, but as you can see, there are multiple. And there are patients that fall in that, and there are patients that fall out of that. So I think it's also important to recognize that as there are many thought processes of what may start the pathway of breast cancer, there is nothing that we know definitively that causes it. So I think it's important for patients to know that they don't do necessarily or don't do anything that actually causes their breast cancer. We have ideas about what may have caused it, but patients don't need to go and change multiple things in their lifestyle to kind of decrease their risk. I think we all try to tell patients healthy, balanced lifestyle and try to control what you can within these risk factors that we kind of hypothesize may increase a woman's risk.
I think that's a really good point because it can seem a little bit overwhelming to think about all the potentials. But if you were to give a couple of things that would be on the top of your list about how someone could lower the chances of getting breast cancer, knowing that, of course, that's not going to guarantee it, what would be some of those things that you would be the top of your list to recommend?
I think on the top of my list is to be physically active, exercising, and trying to keep your weight at a normal weight. I think that's one of the things that patients can do to actively decrease their risk of getting breast cancer. And
I honestly didn't know that. I didn't know that would have been the first thing that you would have said. That's really important information. Thank you.
Yeah. And, and the other thing is, maybe not being on oral contraception if possible, or using non-estrogen based oral contraception. And we're talking about women who are in their reproductive years, who are still menstruating, who need these things, right? So In older women, I think it would still be physically active. Women who are in menopause tend to gain weight. And I think that because of the statistics of, patients over 50 developing breast cancer more often, that the only way that I could try to convince them to maybe reduce that risk is by losing weight and obviously getting their screening, which is not going to prevent breast cancer, but to help catch it early and get it treated and cured.
Which perfectly brings me to my next question, which I want to find out more about, is what is really the best way to find breast cancer?
So as Dr. Elrada kind of hinted, started to talk about screening. We have very, very good screening for breast cancer, annual mammography, plus or minus breast ultrasound, depending on risk factors and how the breasts appear on standard mammography. We have now transitioned to what's called tomosynthesis, also known as 3D mammography, which gives us a really nice picture of the breasts, and it actually decreases recall rate, meaning that once you have a mammogram, a lot of times if there's a finding, you're called back to get additional imaging, and tomosynthesis 3D mammograms have decreased the chance of that happening because the radiologists are able to see a little bit more clearly. It has also increased detection rate slightly. From the standard compared to the standard mammogram. So it is extremely, extremely important to get annual mammograms. Ultrasounds can be helpful, especially in women with dense breasts, because it allows us to see things that a mammogram may not be able to show us. So each modality has their own, pluses and minuses. Another question we get a lot is, am I getting a lot of radiation from my mammogram? Women actually get more radiation from walking through an airport than you do from an annual mammogram. Wow. And so it is very important to get your mammogram, and the sonogram does not have radiation. MRIs are another imaging modality, which we use sparingly. So definitely speak to your physician about if you're a candidate for that. But we recommend mammography plus or minus ultrasound starting at the age of 40 or 10 years before your youngest first-degree relative, and that should happen annually.
Great. So once a woman turns 40, typically is when they should begin their screening for breast cancer. And then you recommend it, you said annually?
Yes.
Okay. Sorry, go ahead.
And I want to emphasize that there are some guidelines out there that suggest every other year based on family history and personal risk. So it's definitely something to discuss with your physician about what your risk is. But I think for the majority of average to high risk patients, annual mammography plus or minus ultrasound.
Terrific. Thank you for that. What are some of the symptoms of breast cancer? Who would like to take that?
So they could come, I can answer that. Thank you,
Terrific.
Elizabeth. So thank you for the kind introduction. And they could, although I don't see them up front, but I could start to say that they could be just found in a screening mammogram or no symptom, where they don't have a symptom. It's just a finding on their annual mammogram. So, but if they were to have symptoms, somebody could present with a lump. I felt something in the breast. Or they feel a nipple discharge. Sometimes it could be a little bloody nipple discharge, a couple of drops of blood, or something like that. So they feel a discomfort, pain, and some vague skin thickening in the area or in the breast. Or they may feel a lump under the armpit, which is called the axilla. So these are some of the general findings or symptoms they come with. And then they say, I didn't have a mammogram for a few years, or especially now in the COVID times, I did not go for about 2 years or a year and a half. And they tell us this type of story. So these are some of the general things. And sometimes patients don't find a small lump, but the lump is fairly large, and they might find a skin irritation and a redness in the breast and a fairly large lump in the breast, or the whole breast feels very hard. This is a variation of the process, like from a small tiny lump, maybe it has become a larger lump, and they never felt anything in their breast. Not everybody examines themselves, so or feels for the lump, and there's just an incidental finding. They just feel some one day in the shower or something. So these are some of the common presentations that we see when people come in with their story.
Thank you for that. And I think, you brought up two really good things. One is that there are all these symptoms, but then there could be no symptom. That's why a mammogram is so important. And also the other thing that you brought up, which I think is really important, is about how COVID may have kept people away from their mammograms, and how critical it is to make sure that you're getting screened and not to let your fear of COVID get in the way of your screening. I mean, is that something that you would recommend, that people make sure that if they are delayed in their screening, that they go ahead and make sure that they get their screening?
Yeah, definitely. And in addition to screening's part of it, I think there's, as Dr. Ravi had alluded to, that there has to be some level of breast awareness. Mm-hmm. Some women are not comfortable kind of examining their own breasts, and so it's definitely important to see your primary care physician and your gynecologist for an annual breast exam, but also just having a sense of what feels normal, what doesn't feel normal to you. Because I have a lot of patients say, well, I try to do breast self-exams, but I don't know what I'm feeling for. And that's a completely normal response. But I think if you become aware of your breast, you'll start to notice if something is out of the ordinary. And that's when it needs to come to the physician's attention. Because what if you're in between mammograms and you've noticed a difference? You don't want to wait until your next set of imaging to pick something up. So it's important to have a level of breast awareness. Also, in addition to exams by physicians or healthcare provider, along with your imaging.
That's a really good point. You don't need to know what you're feeling for. You just need to feel, and then know that there's something different. You don't need to know what that is. I think that's really a great way to put it.
Yeah. And the other thing I just wanted to comment, there's a lot of patients who say, well, I didn't have pain, so I didn't think too much about it. And you don't always need to have pain. You can have pain, or you may not have pain. And sometimes, their thought process is, well, if I don't have pain, it's probably nothing. But most of the times it is painless. So if you do feel a lump in your breast and it's hard, or it doesn't feel like your normal breast, you should bring it to the attention of your provider, whether it be your breast surgeon or your primary care doctor.
Thank you for that. So how do you actually confirm that a diagnosis of breast cancer?
So I could take that question on. So usually it's something that's found on imaging, or a palpable finding that someone feels, the patient or a healthcare provider. And the first step is to image it a little bit better to see what it looks like. Is it a cyst? Is it a solid lesion? And these features can be delineated from breast imaging. If it's a cyst, which is something that's definitely palpable, I've had patients with quite large cysts, and everyone's really concerned about it, and we put an ultrasound probe on it, and it's just a big bubble filled with water. So it's important to get the appropriate imaging done, and then a needle biopsy. So there's two ways that needle biopsies are performed. They're usually done by a radiologist who specializes either in general radiology, or at NewYork-Presbyterian Queens, we have about 10 to 12 breast imagers who specialize in women's imaging. And they will perform a needle-guided biopsy, either with a fine needle that just takes some fluid or some cells, or what's called a core needle biopsy, which is a larger biopsy needle. Local anesthesia is given prior to the insertion of the larger needle, and some tissue is taken out and sent to the pathology lab for analysis.
Okay, thank you. So you go through this, you learn that it's a breast cancer diagnosis. What happens first after that?
Well, I guess there could be a multitude of ways that a patient can get referred to the breast team, because the patient's going to need to be seen by probably multiple people. Mm-hmm. But first, they're probably going to be referred to the surgeon. So Dr. Malik, you want to maybe take on what you do when you see the patient first off in the office, and then maybe we can chime in from our ends afterwards.
Perfect. So usually I see patients with either a clinical symptom or an abnormal imaging. So they'll present to me We'll go over their family history, their personal history, kind of see what their risk factors are. And then we do a full clinical breast exam, which includes checking the regional lymph nodes in the neck and the armpit. And then we do a breast exam. After that, imaging is reviewed, and we also go through the pathology report if we're talking about a biopsy-proven cancer. And there's different features on the report to look at, and that determines what type of cancer we're dealing with, the aggressiveness of it, and the stage of it. And there's two ways we stage. It's a clinical staging based on what we feel and what we see on imaging. And then there's what we call a pathologic staging, which is done based on the pathology report that we receive after surgery. So once the diagnosis is made, we kind of come up with a treatment plan. And that's usually done with a multidisciplinary team. So all of the members, part of the members are on this, this webinar today. So I'm a surgical oncologist, Dr. Elrada is a medical oncologist, and Dr. Ravi is a radiation oncologist. And we work as a team to come up with a treatment plan for the patient. That may not happen immediately right on the spot, but we all know enough because we work together quite often about what the others would recommend to kind of come up with a preliminary plan. And then once a week, we discuss all new cancer diagnoses at the hospital. And we come together as a group, we review all the imaging and the pathology and genetics and different factors that can contribute to a patient's treatment plan. And we come up with an individualized plan for the patient. But it usually starts, as Dr. Elrada had mentioned, in the surgeon's office. Surgery is usually the first step, followed by what we call adjuvant treatment, which is radiation, chemotherapy, pills, or a combination.
So typically surgery is the first step. And again, everything that we're saying is general, and obviously you need to see your own doctor to know specifically what is right for you. But typically there's surgery involved, and then there are other components of the treatment to manage the cancer.
Correct. And it's definitely, and as you mentioned, everyone's treatment is different. Everyone's cancer is different, so it needs to be treated differently. And therefore, the plans are really individualized to a patient's specific tumor biology and what kind of how their cancer presented.
And you mentioned something very extraordinary to me, which is what you do at NewYork-Presbyterian Queens, but is this where you meet together to discuss all different patients. Can you just speak to that for a second? Because I think that's such a phenomenal thing to know that your doctors are meeting with other doctors to talk about you and get all these expertise involved.
Yeah, breast cancer treatment is really a team approach, and so we can't work in a silo, because what I decide to do, for example, the first step for surgery, may then impact what's done from a radiation oncology standpoint or a medical oncology standpoint. So to optimize and to plan the best sequence of events, it's really important to have a discussion and get everyone's input, because we all have our own areas of expertise, and to be able to really find a plan that optimizes the care for an individual patient. And so we do that weekly here at the hospital.
That's incredible. So what else is involved? What would be next in the breast cancer treatment, or potentially next? Obviously, there's no set roadmap. Dr. Elrada or Dr. Ravi
Yeah. So let me take that question. So obviously, for pretty much majority of cases, we start with the surgery. After what Dr. Malik and her nurse assistant and others in the office have put together all the information, the genetic information, whatever is pertinent to each case. The clinical staging is done, and then of course she offers surgery. And in early stage, usually it's breast conservation surgery. So surgery is done, which means we like to save the breast. So women should keep the breast. Having said that, that follows that we have to keep radiation in the picture. So just to give you a historical perspective, about 70, 80 years ago in the 60s, only mastectomy was known in the 50s. So, but for a small, excuse me, for a small 1 centimeter lesion or a tiny lesion, if you do a mastectomy, you lost the breast. So women were losing breasts. So then there's no need for adding radiation, another modality of treatment. So we started doing studies way back then and then learned that we can keep the breast with a smaller or limited surgery, remove the area of tumor, check the lymph nodes, and then supplement radiation to the breast and keep the breast. Women don't have to lose the breast. So we've been practicing this for many, many years now. And as always, we're looking for better and shorter treatment so that patient does not have to come for many visits. For example, if I could elaborate on this, patients in those days used to come for 6 to 7 weeks of 5 days a week radiation. So then in the last 15 plus years, we understood that the same treatment could be condensed to about 3 weeks. So now the standard of care pretty much, I'm talking about early stage cancers, is about 3 weeks. And that is the standard across the country and even in Europe and elsewhere. So now we're looking for even bigger, shorter versions of this treatment and then getting the same benefit or the outcomes. So we are actually having a trial that is called partial breast radiation. That is, we treat the most vulnerable area, which is the area of the operation, with radiation. Of course, we have to choose and select and follow the criteria for this trial that we put together a few years ago. But what I want to point out is this trial is open. So it's not even 3 weeks. If you meet these criteria for the earliest of the breast problems or tumors, you could just get 1 week of radiation. You know what I mean? So there are so many options available. And so I see the patient. Again, what Dr. Malik and Dr. Elrada said earlier, there are other factors in the pathology that we look at. Even early stage cancer, sometimes we look at additional details and they may need some chemotherapy, for example, a systemic treatment, and that would come before me. So Dr. Elrada will step in and see the patient. So we all as a team, as we pointed out, discuss in the tumor boards weekly, and we understand this plan and make this plan for each patient. So instead of me stepping in right away after surgery, Dr. Malik would send the patient to Dr. Elrada first and say, can you please concur or evaluate this patient if, as we discussed, if she indeed meets all the requirements for the chemotherapy. And if there is really no role, and we know it obviously, so I would be the person seeing them and I would initiate that radiation therapy treatment. So Dr. Elrada?
Right. So thank you, Dr. Ravi. So you've touched on a lot of points. I think the role of the medical oncologist is to kind of chime in on where chemotherapy is needed. And we know oftentimes that, in general, it's kind of needed after surgery, but we do it a lot before surgery. And we select patients who would benefit from chemotherapy prior to their operation based on certain things. For example, they may have a large breast mass and maybe some localized lymphadenopathy under the armpit. That needs to be downstaged, meaning we need to give medicine in order to get this tumor to shrink down enough for the surgeon to be able to accomplish a breast conservation surgery. If a patient has a very small breast with a very large tumor, that might be hard to accomplish because, doing breast conservation on a very small breast may deform the breast and it may not be cosmetically appealing. And so we need to judge when the chemotherapy will be in the best interest of that particular patient in the upfront setting, which we call the neoadjuvant setting, which is the setting before surgery. So there are many women out there who do require chemotherapy prior to surgery in order to downstage their breast tumor or their axilla or both, to optimize surgical outcomes in those patients. Those who have smaller tumors, as Dr. Ravi alluded to earlier, who can go straight for surgery, will then have that done. And then depending on what type of breast cancer they have, they may or may not require chemotherapy or additional targeted therapy, depending on their breast tumor type. Nowadays, we have come a long way in deciding who needs chemotherapy and who doesn't, especially in a subset of women who are just estrogen positive, for example. They are HER2 negative, and they don't have lymph nodes involved in the axilla. There is a genomic assay called the Oncotype, for example, that looks at the gene expression within the tumor itself to give us an idea of what the biology of this tumor is and whether or not these patients are going to be at increased risk for recurrence in the future. And that will help us decide whether or not they need chemotherapy plus anti-hormonal therapy, in addition to that, followed by radiation therapy. So there's a lot that goes into the decision-making, and it really depends on each individual patient what they will require.
Wow, that's incredible to be able to really learn about that particular tumor and be able to target, because I'm trying to understand, from what you're sharing with us, being able to target treatment based on the specific characteristics of that particular tumor. I mean, that is incredible.
Yeah, the information that we have now is adjunctive to the information that we ordinarily would have, which is the pathological information. But what we've learned is that, what we're seeing under the microscope doesn't always correlate with how this tumor is going to behave in the future. And we're learning to put the pieces of the puzzle together and making our best, decisions about the patient based on these two pieces of information.
Wow. So what can people do prior to surgery and chemotherapy, radiation, assuming that they have to do any or all of these pieces? What could they do to get ready for that type of treatment?
So from the surgical standpoint, there's not much. It's if you're on any blood thinners, to stop that. Also, definitely in consultation with your physician, because there are indications that are clearly outlined of who needs to be on a blood thinner and for what reason. So we don't want to make something worse by trying to prepare for surgery. So in discussion with your primary care doctor, stopping some of the anti-coagulant medications that thin your blood out, because surgery obviously can increase someone's risk of bleeding, and we don't want that to be increased further from any medication. Other than that, if you smoke, smoking cessation is really important, not only just for your overall health, but also to decrease potential complications from surgery. It does affect wound healing, and any herbal supplements should be stopped, because we also don't know how that would affect wound healing, and also increases potentially the bleeding risk intra-op.
Terrific, thank you. What about Dr. Ravi? What about radiation? What would someone potentially be able to prepare for?
Good question. So somebody who's smoking definitely should have stopped even prior to the surgery. So the reason why we say that is, of course, smoking is not good for your health, especially for your lungs. So the breast, if you look at it where it's located in the body, it's on the rib cage, and just behind that are the lungs. So as you're breathing, your breast moves. So when we target the breast radiation, we are taking into account how much of your lung is moving with your breast. So if you're a heavy breather, like you're short of breath a lot, you have COPD. So we have to consider your nature of your breathing and use the breast, the back end of the breast, which rests on the rib cage, where the lung comes and moves with it. It's right there. So we always caution that could be in the area of your radiation field, that little area of the lung. And so we always caution people that you should stop smoking, because there could be some irritation from the treatment as well. However, having said that, we have developed good positioning techniques, like we now position facing down. So the patient is lying facing down, so the breast is actually suspended. So the body is away from the breast is away from the body. So your body is here, the breast is hanging down. So, but there are people who are unable to be laying on their bellies for about 15, 20 minutes. So there are some challenges we encounter, but overall, smoking is very good for your health. So this technique has almost no lung in our treatment field. Otherwise, we had a tiny sliver of lung based on the chest shape. But to understand, the lung is just behind your breast. So either way you see it, yeah, you're muted. I don't hear you.
You can't hear me?
So yeah. So either way, so smoking is not good for you. So that's very important. So smoking, you should stop. And of course, Dr. Malik said herbal stuff. So a lot of herbal medications or herbs, whatever they have, could cause additional irritation on the skin of the breast. We don't know what they have. So I stop all these medications. Also, radiation, we know how it works for the last 100 plus years. So all these antioxidants, we need the oxidants for the working of the radiation. We need the oxygen and the oxidants if you at the cellular level inside the cells in the body. So if you do antioxidants and heavy duty antioxidants and herbal things, which all possibly can negate the effects of the radiation. So we try to stay away from those. We don't know too much about them. So let's keep them away for about a month till we, you're so passionate about it, you can take it after if you want, but then spend a lot of money, I guess. But we try to keep it away because you took the trouble to do the treatments. Why not do it like we know it best? Okay, so that's another recommendation I have. Of course, wound healing, they should be ready, and Dr. Malik will only send them to me when they're almost ready. And then we start the preparation process of measuring the area, the breast and whatnot. So that is what I look for. And during my consultation, I go over all these aspects.
Great, thank you for that. Very, very interesting. Who thought antioxidants? Just go think you need oxidants for Dr. Elrada, what about for you with chemotherapy and treatment?
Yeah, so I mean, everything that Dr. Malik and Dr. Ravi said, I agree with. I mean, I think smoking is bad for you, period. It needs to stop. In general, I think it's more of an emotional support that we need to provide to women prior to chemotherapy. They do need to understand that their life is going to change a little bit, and logistics of going to work and children and things like that. I mean, we do spend a lot of time counseling patients about what to expect. In terms of their overall health, we do try to eliminate things that they don't need. So, a lot of antioxidants or herbal medications, or if there are on oral contraceptives, which should have been stopped way long before. Getting their nutritional health in order, trying to have them see a nutritionist, physical exercise. We want to try to keep their daily activities in their life as normal as possible through chemotherapy. Obviously, that's very difficult. But what I found is, just reviewing their medication lists, if there are on any medications, to make sure that they don't interfere with the chemotherapeutics that we're about to give, making sure that their liver, thyroid, and chemistry tests and blood counts are at baseline before we start treatment. So some of the things that we go through with them in the office. But I think a lot of it has to do with support at home, support from partners, spouses, children, who's going to be bringing them, who's going to be taking them home, and giving them the outreach, to get to us if there is a question or a problem, whether it be a phone call, email, coming into the office, making sure that we're available to them, because it is a hard time, and everyone has variable side effects. And not everyone's going to breeze through chemotherapy. We do have patients who do, and we have patients who don't. And we just want to make sure that we assure them that we are there to walk them through the process.
Terrific. Thank you. Very well said. So maybe you could start with us, Dr. Elrada, talking about some of the risks and side effects, and also how we can reduce some of those risks and side effects from the different treatment options.
Right. So, there are different chemotherapeutics and there are also different targeted therapies depending on the type of breast cancer the patient has. And, in general, chemotherapy is a medication that goes into the bloodstream that does not know the difference between a cancer cell and a normal cell. So it does harm normal healthy cells. And that is the reason why patients get side effects from chemotherapy. So, things like hair loss, alopecia can happen from chemotherapy. That is a notorious side effect of chemotherapy. Fatigue, change of smell, change of taste, loss of appetite, muscle aches, pains, diarrhea, indigestion problems, and so on. So there are various types of side effects that may happen. There are treatments that do require heart monitoring, for example, like some of our anti-HER2 medications that patients do need to have a heart ultrasound every 3 months and monitor their heart function. We do, and neuropathy. Neuropathy is another big side effect that can be encountered through some of our chemotherapeutics. So during this time, there are over-the-counter medications or prescription medications that we may employ or give to the patients in order to minimize some of these side effects. There are medications to help with appetite if we need be. There are medications to help with their neuropathy, with their muscle pain and things like that. What we encourage, however, is, plenty of hydration and good healthy eating habits to get them through their chemotherapy. Take the rest when they need it. Listen to their bodies when their bodies tell them that they can't do something. That is really important. For women who need to work, we tell them maybe you need to take the week off after chemotherapy and then go to work in between. We try to help them, logistically, get that going because, some women can't afford to stay home during their treatments. And so there are a lot of things to help them minimize side effects, and they just need to have an open conversation with us about what those side effects are so that we are able to help them in the best way that we can. We do have a clinical nurse. We do have our nurse practitioners, myself, and our other staff members that are here to help and reassure the patients and give them guidance depending on what the side effects are.
Thank you. Thank you for that. What about Dr. Ravi? What about in terms of radiation, in terms of side effects and what you can do?
Sure. So the radiation, unlike chemotherapy, it's not going through the body. So it's very localized, just like your operation. Operation is only addressing the area in the breast and under the armpit if they're checking on the lymph nodes. So my area of treatment is limited in that area. Sometimes we treat not only the breast, even under the armpit, if multiple lymph nodes were showing some tumor cells there based on the report from the pathology. Otherwise, if it's just limited in the area of the breast, we just treat the breast. So, so when the radiation is not like one day, as I just explained, it used to be several weeks. Now it is, let's say, 3 weeks. In certain cases, we do have to go a few more weeks based on the report and the size of the tumor and other details. However, for a regular 3-week radiation schedule, they're coming 5 days a week, Monday through Friday. It's a half-hour visit. The first step is a preparation, which is called the simulation or planning process, because the anatomy of each breast is different, the size, shape is different. So we have to capture all this information in a CAT scan, which is in our department. So that is called the first step of simulation. So the patient comes back after my consultation. I'm there with the patient in the CAT scan, and we position them, like I told you, facing down. The breast is under the table. It's a very convenient and good technique. So if somebody is not able to, we have a different way also. So it's not like that's the only way. So because always our goal is to protect the additional structures around the breast, like the heart and the lung. So that's always our goal. However, we try different positions. So positioning, capturing the CAT scan information of your body part, the breast and the regional area, and then we mark you so that we know exactly how we position you for your return visits. So about a week or so later, we are ready with the plan in the computer. The team here, the medical physics team in my department and myself, we prepare a custom plan for each patient based on their measurements. And it takes about a week, and we give a return date to the patient returns, and then we go to our treatment machine, which is just a big old x-ray machine. So they have gotten more, they're better and sophisticated, let's say, but it's actually a big old x-ray machine. So more computers and whatnot, and faster, but it's really an x-ray machine because you're giving x-ray to treat this area. So they're positioned back again, and then we do a verification, and then the treatment is only about 3 to 5 minutes. The appointment is half an hour. People think that, oh, I'm getting half an hour of radiation. No, it is just the verification, coming, changing, getting in the room and setting up. All those are additional 5-10 minutes. But once they get used to it for the daily appointments, it's 10 minutes or 15 minutes in and out of the department. So that's the daily setup. So every day they will come at their chosen appointment time, and then they go home. Once a week, they see me and the nurse to see how things are coming along. And this is where we check for the side effects. For example, it's a few minutes every day. It's like sitting in the sun, soaking up the sun at the beach. So in there, you're going to get a tan all over your body, if you're lucky, maybe after about a few hours. But here it's only a few minutes. So remember, the whole program is only 3 weeks. So when we used to do 6 weeks or so, we used to get a tan by the end because we're going slow and slow and slow and daily. Here in 3 weeks, any changes generally we see in the last few days of their treatment. But it continues into the 4th week when they're at home because it's still working. So we give a discharge phone call and check on them. How's your breast looking? Sometimes we see additional redness. It's like suntan, redness, dry skin, but it's limited to the area of the treatment. So people sometimes think maybe they'll get a facial tan. No, so it's only limited to the area of the treatment. So I watch for giving any topical creams, very simple. Sometimes if there is some peeling like under the breast or under the armpit, it's a friction area, we may give a prescription ointment for a week or so, but no nausea, no vomiting, no losing hair from radiation because we're not treating there. We're just limited to our breast area. So those are the simple side effects and can be taken care of very easily. So the diet has no restrictions. Only thing, no antioxidants and no heavy duty, like a big bag of carrots, juicing it all day. No, stay away from that. But regular diet with some carrots, some spinach, no problems. So I say follow regular diet, take all your medications, just normal, be with the family, children. Sometimes people think, oh, I have to be in a different room. No, you're not carrying back any radiation. This is just an x-ray and you're going home. So just a local skin discomfort, a little sensitivity in the breast. Sometimes a generous breast person may have a little swelling in the breast. That could happen after surgery too. You just feel heavy. So all these will subside as time goes. So it's individual, but will subside. So these are the general things that could be expected.
Thank you. Thank you for that thorough explanation and also for dispelling some of those myths. I appreciate it. Dr. Malik, after surgery, can you share with us some of the side effects and what one can do to prevent them or at least make them less?
So no side effects from surgery, just kidding. For, any incision anywhere on the body is going to have some discomfort. Surprisingly, the breast does very, very well. We usually do not even prescribe any strong narcotics after surgery of the breast. If a patient's having a mastectomy, it's a much larger procedure, so that's a little bit of a different story. But for all of our patients who are undergoing mastectomies at our hospital, everyone gets an injection in the upper back, similar to when a woman's in labor and gets an epidural. So that really helps with pain control for about 12 to 24 hours after surgery, and it's decreased the amount of pain and medication that a patient requires. But for breast conserving during surgery where it's same day surgery in and out, and there's a small incision on the breast and maybe in the armpit, just Tylenol over the counter and ice packs to the areas where we did surgery is more than enough. I have patients that say I haven't taken a single Tylenol. I have patients say I took it for a day or two. So it's a really well tolerated procedure. Any surgery has risks of infection and bleeding, so we mitigate that as much as we can intraoperatively. But the only really restrictions are you want the cuts to heal. So about 2 weeks, don't want the cuts to be underwater for extended periods of time, like in a bathtub or a pool, but most patients can shower within the next 24 to 48 hours. Nerve pain is a thing. So whenever we make an incision, nerves are cut. So that may create some discomfort, some pins and needles, kind of poking sensations in the breast. That may persist for a while. I'm talking about maybe even months, but it'll become less frequent as the nerves kind of settle down. But other than that, very minimal side effects after surgery.
Terrific. Thank you for letting us know that. And I, just want
to add a point there. Dr. Malik mentioned mastectomy, and sometimes if somebody needs a lot of lymph nodes to be removed under the armpit, we caution them about a lymphedema. That's possibility, and Dr. Malik has a wonderful team who keeps a good eye for those symptoms, and sometimes we are proactively sending them as well to our physical therapy clinic, just with a little tingling and whatnot. And once patient needs, on top of this radiation after this to that area, sometimes they do, and because of the nature of the detail of the report and the pathology. So it adds a couple % additional risk after the surgery. So lymphedema is a possibility in such, in such patients. And but we have good techniques to, I think we talk about it during our consultation and after the surgery, and during my consultation as well, like don't lift heavy weights, groceries, pocketbook, big pocketbooks. So all those kind of general things that we should be mindful of. You forget you have a big pocketbook on that side, so you got to move it to the other side. Vacuuming, those kind of general things, they do understand those things as well.
That's a good point. You say don't lift anything heavy. Yeah, you're carrying your purse that's 50 pounds. You're not even realizing it. So that's a very good point to make.
Tell patients to not lift a phone book, but who has phone books anymore?
Right. Now it's just our purse, which is a weighted backpack that's always with us, I suppose. So just one question. Lymphedema, you said, what exactly is that? Because I'm not familiar with that term, and perhaps if someone is not at that stage, they might not know.
I can take that on. So lymphedema is swelling of the arm. It happens usually when we're taking out a lot of lymph nodes. Usually during early stage breast cancer, we just take out a few. It's called a sentinel lymph node biopsy. The risk of getting swelling of the arm, lymphedema after that is pretty low. It's not zero, but it's low. When we do further axillary surgery called an axillary lymph node dissection, where we have to take many more lymph nodes, plus or minus radiation, as Dr. Ravi had mentioned, the risk of lymphedema, swelling of the arm, goes up. So we just have to take precautions to reduce infection because the lymph nodes usually clear infection and cancer and other processes from the body. So when they've been removed, there's not as many of them, they don't work as well. And so the risk of getting an infection in the arm and then subsequent swelling can become problematic. So we have a lymphedema clinic, which is run by our physical therapy team and our occupational therapy team, where they show range of motion exercises to kind of get the fluid moving and out of the arm. We also have services that we can provide for patients that are called, like with lymphedema pumps. That's like an active massage pump to kind of get that fluid out of the arm and help with the drainage.
And that's all part of the New-York-Presbyterian Queens team?
Yes.
So it's like you really have a whole, it's kind of you come there and you have a whole team of experts who are looking at your reports and looking at your breast and making the right decisions for you. And then each step along the way, it really sounds like it's hand holding. I mean, as you all speak, I kind of feel myself exhaling, because there's this sense of, I want to go like this, because it feels like carried through the process, which, as Dr. Elrada said so beautifully, it's really so important to have support. And I think, this is what we're talking about here, is moving through this with support. So I want to jump to another question, because I know that people think about this very often ahead of time, and, and when would be the right time, but genetic testing. If someone has breast cancer, do they need genetic testing then? Do you recommend it if you don't have breast cancer? What are your thoughts on genetic testing?
So we have genetic counselors at the hospital. There are certain criteria, family history, personal history, that may increase a woman or a man's lifetime risk of developing breast cancer or any other cancer. There are syndromes also, which increase a person's risk of multiple different types of cancer. So there are certain criteria that we follow that are kind of standardizing guidelines about who's a candidate and who's not a candidate. So everyone is evaluated to see if they're a candidate for genetic counseling. So there's a difference between genetic counseling and genetic testing. So a lot of people are candidates for counseling, but they may not be candidates for testing. Only about 10% of breast cancers are from a genetic cause. And so we have to be very careful about who we're recommending for testing and who we're not, because sometimes we can get an uninformative result. And then what do we do with that? We may not have enough information, and there's a lot of anxiety and worry that comes along with that. So we have to be very careful about who we're offering testing to and who we're not. So we have specialized genetic counselors at the hospital that we refer to determine if a patient's a candidate for testing or not. I know somebody had posted a comment, but what about men? So men do get breast cancer. It's less than 1% of breast cancers, and all men with breast cancers are candidates for genetic testing. In my practice, I've seen men with cancer that are genetically positive, have a mutation, and those that don't. So it doesn't mean that if you're a male with breast cancer, you definitely have a genetic mutation or an abnormality. But that is something that we take into account when we counsel our patients and we go through the consultations.
Thank you so much for that. Does anyone else want to add anything to that in regard to genetic testing? That sounds like very, very thorough answer about that.
Male breast cancer, they don't get mammograms. So if they see something like a nipple discharge, a lump, you have to go quickly and not think it's nothing. And, so unlike women get mammograms. So definitely then we, of course, do a mammogram and the necessary workup. But definitely men, if they see something unusual in the breast area, definitely go to their physicians to see what is going on.
Thank you for that.
I wanted to piggyback on to something that Dr. Malik said about genetic counseling. And, if there is a positive result, it may impact treatment altogether. From a surgical standpoint, we may be offering bilateral mastectomy, for example, or we may be offering a bilateral oophorectomy, which is removal of the ovaries. So the discussion then becomes a longer one if we do discover a mutation like the BRCA1 or 2 mutation that puts patients at very high risk for developing breast cancer in the future, as high as 80%. So these women need to be counseled for their positive result, and then need to check back in with surgery and medical oncology, whatever that plan was initially, if may alter or may be different depending on that result when it comes in. So we try to get the genetic testing done as soon as possible so that we have those results to make that plan moving forward.
Great, thank you so much for that. My goodness, this information, you've been also thorough. I truly appreciate it. I want to respect your time. We do have a few questions, if that would be okay with you, just to jump to them quickly. And I just want to start out by saying there are some questions here that are very specific to the individual, and that you're going to be addressing these generally. So please go see your doctor, or these doctors, please. I shared the website here, and we're going to share contact information as well. So please don't hesitate. But Delia had said that she had her routine mammogram and everything was fine in June, and then in October she had pain in her areola and nipple in her right breast. The gynecologist told her to stop consuming caffeine. She was having chocolate at the time. And after a week, the pain subsided. She had a sonogram in the area. The radiologist said everything is fine. She has no trauma to her breast. So her concern was, why would she experience that pain in that particular area of her breast? I know it's a very specific question, but I don't know if there was some general advice on that.
So we see a lot of breast pain. Breast pain, first of all, is usually not a sign of breast cancer, so that's a good thing. Breast pain can come from multiple kind of pathways. Cystic breast can be painful. So cysts are like bubbles filled with water. You can think of them as little sacs. They're very sensitive to hormonal changes in the body. So sometimes right before your period, they may get a little larger, push on the surrounding breast tissue and cause discomfort. Sometimes there could just be nipple sensitivity and irritation from a bra or from a detergent or what it may be. It's more of a skin thing that can cause discomfort. Also, there's a large muscle underneath the breast. And so if you're working out or if you're lifting something heavy or you sleep a certain way, you may cause irritation of the actual muscle underneath the breast, which kind of is referred to the breast itself, but it's not the breast, it's the muscle underneath. So there's multiple reasons that a patient can have breast pain. Caffeine is an interesting thing that was brought up in the question. There are studies that show that increased caffeine intake does increase breast pain, but then there's other studies that show completely the opposite data. So it's hard to say. I always tell patients that it depends on how much you value your caffeine and your cup of coffee. So it's not just about decreasing, it's about eliminating. So most patients that have a sensitivity to caffeine, and it may or may not be related to the breast, have to completely eliminate. So no coffee, no tea, no soda, no chocolate. So I'll take a little bit of breast pain to have my cup of coffee a day. So, take it with a grain of salt. It may or may not be helpful or related.
Do you think that she did enough? If she had an ultrasound and radiology, because I think that would be the only concern, right? Did I do enough to make sure that it was nothing dangerous?
Yeah, I think a mammogram and an ultrasound would show any abnormality of concern.
Perfect, thank you.
Yeah, I think the fact that she even went to her doctor about it needs to be applauded, because most women do not go to the doctor if they feel something in their breast and just kind of say, I'll just see what happens. And then months go by and then something, starts to form. So I'm glad that you went to your doctor. That was the right thing to do and got the necessary testing done. And that's what we should be telling all women. Whether you think it's big or small, you should just get it checked out.
Perfect thing to say. Thank you for that. Terry wanted to know, can a cyst turn into breast cancer? And also, should a cyst be removed, or is it okay to just leave it?
So I'll take that one. Cysts, there's different types of cysts. So if it's a simple cyst, which is a nice black circle on the ultrasound, there's certain features that'll determine if it's a simple cyst, a complicated cyst, a complex cyst. There's different terminology that radiologists use based on the appearance on the ultrasound. If it's a simple cyst, it is not worrisome. Don't have to do anything about it. It does not need to be removed. If we were having this conversation 30, 40 years ago, a lot of times at that time, I have a lot of patients who say, oh yeah, I had surgery for a cyst. That doesn't really necessarily need to happen, but we have better technology now. We can see things a little bit better. If it's a complicated cyst or a complex cyst, we sometimes check it again in about a 6-month time period just to make sure that everything is okay, because then it may have what's called a solid component, and in addition to a cystic component, so it needs to be followed just to make sure, but not everything needs to be removed. And a lot of times for breast, we don't remove things until we do a needle biopsy to kind of determine what it is. Oh, you're muted, Elizabeth.
Thank you. So someone was saying that they went to a top mammography facility and had a terrible experience. It was a lot of pain. They had breast discomfort afterwards, and so they were concerned about what extent can mammograms actually harm women, especially women with larger, more cystic breasts. Are there any links, she's saying here about potentially links between breast cancer due to mammographies? Can you give us some clarity on that? Because I think it's so important for people to have the evidence and the real story on this.
So mammograms are uncomfortable. We've all had them. There's a lot of squeezing going on. They're going to be more uncomfortable for some versus others. It just depends on your your pain threshold, and also what your breasts look like. Sometimes the radiologists need better visualization and do need a little bit more compression. What we do recommend is try not to go around your period where your breasts are going to be more sensitive. Try to go maybe about a week after, when your hormonal levels are a little bit low and more stable and you have less breast swelling and discomfort. You can also take a Tylenol or a Motrin before you go, about 1 to 2 hours. That may help with some of the discomfort. But it's a really important test that gives us a lot of information. Most women just have to do it once a year. So try to do whatever you need to do to make it as comfortable for yourself. Let the technician know so they can try to change your positioning to make you a little bit more comfortable. There is a very minimal dose of radiation when it comes to an annual mammogram, so it does not increase your risk of breast cancer.
Thank you for clarifying that. I appreciate it. We certainly don't want people not going for mammograms. Another question about mammogram, DB said, I just had a mammo a month ago, which showed no problem, but it did show that I had dense breasts, and an ultrasound was told that an ultrasound might be worthwhile. I don't like excessive treatment. I also didn't hear from the gynecologist. So how do I determine if an ultrasound is prudent? I have no breast cancer in my family. I'm in my 20s. In her 20s, she had a cystic breast, which was removed and was benign and has never had pain since, and is currently 66.
I'm a proponent for ultrasound. I feel like each imaging modality has its own benefits. There are certain things that mammograms are really good for, and there are certain things that ultrasounds are really good for. When a woman has dense breasts, it's just harder to see on mammogram in terms of there's like a small little lesion that's somewhere in there. So when we look at a mammogram, breast tissue is white and fat is black. Abnormalities are white. We can't see white on white, so an ultrasound can help the radiologist see a little bit more clearly. And so if your breasts are dense, it's not an increased risk of radiation or anything like that. It's a simple test that can be done, and I would encourage women to go do that.
Thank you. And one last question. Delia wanted to know, what about fat and, I'm sorry if I mispronounced this, necrosis? Mm-hmm. I didn't know that term before. What is that okay? And should that be removed? Should they be removed?
So fat necrosis just means dying fat cells, which can happen from multiple causes. It could happen from trauma if you were in a car collision and the airbag deployed, or if you fall on your chest and you have a lot of bruising, and surgery, whether it's surgery for cancer or benign lesions, or if it's cosmetic surgery, breast implants, breast augmentations, breast reductions. Anything that disrupts the blood flow can cause dying fat cells. And so fat necrosis is a benign finding. Usually radiologists can differentiate fat necrosis from other findings in the breast. And so if it's a deemed fat necrosis, nothing needs to be done.
Terrific. Thank you. Before we go, just quickly, if each of you would give one piece of advice that you would give to a friend, and I'm sorry, you didn't prepare for this. So just something that you would tell a good friend or a family member. When I have such experts like you, I just love to be able to give everyone kind of an inside tip of like the most important thing maybe you would tell someone important in your life that you could share with us tonight.
I would say information is power. Some of these tests can be scary because you don't necessarily want to have to deal with the results of it, but screening is important. It allows us to pick up on things and treat them at an early stage where treatments we may be able to minimize and de-escalate treatment. So I know that there can be a lot of fear. I mean, I get nervous when I go for my mammogram, but information is power, and then we can act on it. And breast cancer is a very treatable disease process, and hopefully we can keep it like that.
Perfect. Thank you so much. Dr. Elrada, I see your mute is off, so you're up.
Yeah, so I agree with Dr. Malik. I think the key here is to learn your body, learn how to do a breast exam, on yourself. Even if it may feel uncomfortable, maybe you can ask your doctor, how do I perform my own breast exam, and try to learn your body from now or at a younger age. If your mother had breast cancer, if your aunt had breast cancer, know your family history, know what's going on around you. and educate yourself about those things and ask questions. I think that's the key here, is that if you have a problem and you don't know where to go to your doctor, or ask someone what they think you should do if there's something that you're concerned about and you don't know what to do next. But in terms of breast health, I think it's really learning about your breasts, how they feel, the differences that may appear along the way that need attention, and that you seek that attention immediately and not wait for, time to pass before you do that. Because as Dr. Malik said, it is very treatable and curable if caught very early. So our goal is to prevent breast cancer, but also if we catch it, to treat it and to cure it as much as possible.
That's terrific. Thank you so much. And Dr. Ravi?
Yes. So again, mammograms are very important, very easy. It's once a year, like you do your blood work every year, and age 40 onwards. Don't put off because it's COVID. I mean, just for a brief period, we had some issues, but I think it's a good one. Now everything is available. So mammograms are very important. And know, like she said, know your body. Anything changes, don't hesitate and don't put it off. That's important. But if you were to need treatment, like I explained, we have gotten less time frames and much better outcomes and simpler ways of treating, and less number of visits. And like you mentioned in the beginning, some alternative complementary things like Reiki and other things I have looked at, which as a team, we can again look at other things as well. So a lot of things are available. It's a team approach here at NewYork-Presbyterian Queens, from diagnosis to treatment and afterwards. For your well-being, we engage the social workers as needed, nutritionists. So it's not just us three, the genetic counselors. So many people come and work with us as a team. So very important. So we treat you as a whole. So it's very important, and the family members as well, because they are with you and they go through a lot when a mom or a sister or a daughter comes here for treatments. So again, come back to the mammograms, take care of your general health, stop smoking. Those are the important things, general health.
I mean, that couldn't have been a more perfect ending to this time together. Thank you, Dr. Elrada, Dr. Ravi, Dr. Malik. This was really informative. Thank you for your generosity with all of this incredible information. And I want to give everyone tonight, I don't care if you're 20 or you're 80, give yourself a breast exam, learn about your body. I think if we can get everyone to learn about their body, go for their mammograms, reach out to NewYork-Presbyterian Queens. We're going to send you information how to get in touch with the doctors, and make sure that you take good care of yourself. Thank you so much, doctors, for your time. Thank you to all of our attendees for joining us, and we'll look forward to seeing you on a future webinar. Have a great night, everyone.
Elizabeth.
Thank you.
All right. Thank you.
Bye.
Bye.